Welcome to Onc Now, the podcast bringing you the latest in oncology research and clinical practice. I'm your host, Dr. Jonathan Sackier, and today we're thrilled to have Dr. Joan Carles with us. Dr. Carles is a renowned medical oncologist with extensive expertise in genitourinary cancers, sarcomas, and early clinical research. He's the head of the Genitourinary Central Nervous System and Sarcoma Unit at Vall University Hospital in Barcelona, and is deeply involved in pioneering clinical trials for prostate, kidney, and bladder cancer treatments. We'll be diving into his fascinating research, insights into cancer therapy, and his vision for the future of oncologic treatment. So please stay tuned for an enlightening conversation with one of the leading experts in the field of oncology. It's our pleasure to welcome Dr. Joan Carles to the podcast. So, Dr. Joan Carles, thank you so much for joining us today.
Thank you for inviting me to participate.
A real pleasure. And as we were just saying, I'm a huge fan of Barcelona. I love the vibe of the city, the art. Although every time I've gone there, I've never been able to get tickets for the Sagrada Familia. I have walked around the cathedral many times, but I've never been inside.
I think that it's important you have to book it previously in 1 month at least.
Yeah, so I must plan a proper trip there. But for people who haven't been, the work of Gaudi, the food, the wine, the people, the climate, Barcelona is just a lovely, lovely place. So let's get into the meat of this. Joan, your research interests span clinical genitourinary oncology, sarcoma, and translational research in angiogenesis. How have recent developments in anti-angiogenic therapies impacted treatment strategies for genitourinary cancers and sarcomas?
Okay, so first of all, I would like to say that and point out that I'm leading this miscellanea unit that includes also CNS, but I am mainly focusing in GU and sarcoma, but not in all the tumors because it's impossible right now, according to the evolution and the knowledge, to be leading all this pathology. After saying this, I think that anti-angiogenic therapy has changed mainly genitourinary tumors and mainly kidney cancer, because since 2000, in the first part of this century that we develop anti-angiogenic therapy, it has been evolving during these years, and also it has changed we know the importance of anti-angiogenic therapy in kidney cancer combining with immunotherapy. So I think that both treatment are really important in kidney cancer. In sarcoma, probably there is less evidence that anti-angiogenic therapy works, mainly in synovial sarcoma that may have a role. And according to this, pathopanib has been approved in second or third line sarcomas treatment.
This was if I remember correctly, the angiogenic work came out of the laboratory of Dr. Judah Folkman. Was that correct?
Yeah. Yes.
Yeah. It's interesting, isn't it, how long it takes to go from a scientific observation to a treatment becoming mainstream. It's over 20 years now, right?
Yeah, the 20s. So in early 20 in 2000, there was the one of the first reports that bevacizumab may work in kidney cancer, and since then, different antibodies, GEIS has been developing in kidney cancer and has been the main treatment for the last 10 years. And in the last 6-7 years, it has been demonstrated that combining with immunotherapy, also we may improve the response rate of this combination in kidney cancer.
Yeah. So, changing topic slightly, given your expertise in resistance mechanisms to different treatments, what are the most promising strategies you've encountered to overcome resistance in genitourinary cancers, GU cancers, particularly prostate, kidney, and bladder. Maybe you can deal with each of these in turn.
Well, I think that in prostate cancer there has been many changes because we don't have to forget that 20 years ago we only have docetaxel as a chemotherapeutic agent that demonstrated improvement in overall survival. Since then, different treatments, hormonal treatments that are more potent than were previously used. Also, diagnosis, I mean that we have treatment that may localize the tumor by PET and then give different drugs according to this. Also, we have been developing PARP inhibitors in those patients with alterations in the genes implicated in the recombinant in the repairing of the DNA. So I think that we have different treatments that may overcome the resistance to the previous one according to the alteration and the biomarker that we have right now.
Right.
In kidney, I think that the main way to overcome resistance is developing the HIF2 alpha inhibitors. So there is another mechanism that it works after anti-angiogenic therapy and of course immunotherapy and different kinds of immunotreatments may overcome the previous resistance of the immunotherapy.
And bladder?
And in bladder, probably we have new drugs that may overcome the resistance to chemotherapy, and the main drugs to overcome this resistance is the immunotherapy and also the antibody drug conjugates that are under developing and combining immunotherapy with ADCs, these anti-drug combinations.
Right. So I know you're interested in early and translational clinical research in genetic polymorphisms. Can you elaborate on how genetics are influencing personalized treatment strategies in GU cancers?
From my point of view, genetics and polymorphisms basically may modulate, first of all, the metabolisms of the drug that we commonly use in the treatment of those patients. I mean that according to the polymorphism that have different patients, we may have a lower dose of the active drug in the body or a higher dose and increase the toxicity. And also, according to the polymorphism, also we may check for different sensitivity to different treatments like radiotherapy or chemotherapies according to these polymorphisms.
So, remembering back through my training, sarcomas have always represented some unique challenges for treatment. How has our understanding of sarcoma biology led to different and new approaches in therapies?
Well, the main problem that we have in sarcoma, we don't have to forget that they constitute only 1% of all solid tumors. I mean, that is are rare tumors. And also, we have more than 60 different types of sarcoma. So we split a lot of different tumors and we try to treat all with the same drug. This is not common sense. So I think that from my point of view is the first of all is to have a good pathologist that could identify which kind of sarcoma is in front of us. And also sometimes Next generation sequencing may help to correctly diagnose the patient. There are different studies that has demonstrated around 5 to 10% of the patients, the diagnosis may change according to the NGS studies when we apply these new methods into the patient. And of course, in the last years, multidisciplinary teams that are involved in most of the area in the treatment of oncology is important. And I think that from my point of view, is more relevant that these multidisciplinary teams work together in this kind of tumor that are rare tumors.
Yeah. Yeah, well, the role of the MDT throughout oncology has matured such that it's de rigueur. It's a critical part of patient management. So, I know you've been a coordinator of multi-center clinical trials for new drugs in GU cancers. What are some of the most exciting novel therapies or drug combinations that are currently under investigation that have the good Dr. Carles excited?
Okay, I think that in prostate cancer, I think that looking for new drugs that target the androgen receptor, but not only in the labeling part, that we have to look for different drugs that may act in the cofactors that modulate the expression of the androgen receptor. Also, right now we have the PROTAC there are drugs that try to metabolize and to degrade the androgen receptor. And the main problem that this drug have that is the degradation is mainly focusing the structure of the androgen receptor, and not all the androgen receptor can be the different mutations in the androgen receptor may be degraded. Also, the ADCs, the antibody drug conjugates, diagnosis, I think that is important because we are developing diagnosis with antibodies, with alpha emitters, not only beta. And I think this kind of new drugs may help. And there are some immunotherapies that has demonstrated a huge activity in prostate cancer when most of the people think that the prostate cancer is a cold tumor and immunotherapy doesn't work. On kidney cancer, I think that different immunotherapies are under developing, and also drugs that overcome the extenuation of the lymphocytes, so they allow the lymphocyte to reactivate and be working. And in bladder cancer, I think that the ADCs will take an important part as a new drugs in bladder cancer.
Yes, I remember seeing a recent publication about targeted alpha therapy with actinium-225 in men with castration-resistant metastatic prostate cancer, and it seemed to have some pretty exciting results.
Yeah, the main difference between alpha and beta emitter is that the alpha emitters provoke a rupture of the two branches of the DNA. That with the beta is the lesion in the DNA is even smaller, and this allowed to the patients that could be a higher activity in patients with prostate cancer. But also, right now we have other drugs like zirconium that is under developing in kidney cancer. So this probably diagnosis will be also applied in the next years in kidney cancer.
Right. Well, watch this space, and nice to know that there are options coming down just at or over the horizon. So, as a founding member of the Spanish Society for the Treatment of Genitourinary Cancer, and with your extensive experience in oncology, what do you consider to be the most critical areas for collaboration and knowledge sharing among oncologists to advance your field, especially at a time, without getting political, where, shall we say, international collaborations are becoming a little bit more problematic?
Well, I think that at least in Spain, um, in GU, in genitourinary tumors, sometimes there are no good relationship between urologists, medical oncologists, and radio-oncologists. So my point is that we have to work together. So I have been always trying to put in the same site a multidisciplinary team because it's much better for the patients. Also, collaborations for with uh, people in the lab. So I think that is a close collaboration between people in the lab and trying to uh, give them which are the important questions for in the clinical research to know, because sometimes in the lab they are thinking about other things that are not relevant for our patients. And of course, the international collaboration has to be taken in account and important. And we have the example of sarcoma, so it's impossible to work only in your hospital because, as I say previously,
They're rare.
with the 1% of the
Yeah.
whole tumors, it's impossible to make any advance in the knowledge of this kind of tumors.
Yeah.
And
Very much.
to build networks, European networks, that could treat all these patients. I think that is really important.
Yeah. Very much so. Well, we can only hope that sense and
Yeah.
wisdom overcomes political expedience, and that we can that these people will not stand in the way of us sharing our knowledge and our compassion for our patients. So, a final question for you, Joan, which I like to ask people: if you had 3 wishes for your area of healthcare, what might you wish for?
My first wish wanna be to have predictive biomarkers to treat our patients accordingly. Because from my point of view, in prostate cancer, we only have 2 biomarkers. One is DNA alterations to treat with PARP inhibitors, but this is only account for 20% of our patients. And probably the PET CT with a SUV higher that may benefit most of the patients. We don't have any biomarkers in kidney cancer because all the biomarkers that we have previously defined in a study, when we try to apply in another study or another cohort of patients, it doesn't work. And the same for bladder cancer and sarcoma, of course. The other important thing is also, and related to this previous one, is in prostate cancer. In the last year, we have been focused in escalation of the treatment and to try to improve the overall survival of our patients, but not all patients need to be intensified. So it could be interesting to know which patients can be de-escalate and obtain and avoid the toxicity of the new treatment. I think that this is really important. And my last wish probably will be related to the Spanish Ministry of Health that and the finance of the treatments, because probably we have a good health care, but the problem is how to finance and all this treatment, because some treatment are not financed in Spain, like a combination of anti-angiogenic therapy and immunotherapy in kidney cancer, even that the EMA has approved the treatment 6 or 7 years ago. So these will be my 3 wishes for our patients.
Well, we can only hope that they come true. And I'd like to thank you, Dr. Joan Carles, for spending some time with us today and for everything you do for patients living with these malignancies. Thank you, sir.
Thank you so much for inviting me. It's my pleasure.
Well, I hope you enjoyed that episode of Onc Now, our bi-weekly podcast. If you did enjoy it, please consider subscribing on Apple Podcasts or Spotify or wherever you get your podcasts so you never miss an episode. And please like us on social media and tell your friends and colleagues. And check out our archives because they're growing. And please join us in 2 weeks for another fascinating episode. Until then, I'm your host, Dr. Jonathan Sackier. Please, everyone, stay safe, stay well, stay curious. Bye for now.